Good afternoon to everyone joining us for our expert webinar series. We'll give it just a couple minutes for everyone to join and then we'll get started. Good afternoon for everyone joining. We'll go ahead and give us just a couple more minutes for everyone to join and then we'll get started. For those joining, we'll give it just another couple more minutes and then we'll go ahead and get started. Good afternoon, everyone. We see those attendance numbers that are slowing down, so we'll go ahead and get started. Welcome to our first installment of our Digital Quality Expert Webinar Series. I am Allison Lance, the Director of Digital Quality Community here at NCQA. We're very excited to bring this session and this new series to you. This is our inaugural event, kicking off a series where we are inviting industry experts to come and talk with NCQA and our customers and those who we work with to really dive into how we move into the digital quality transition and their experience and share their knowledge with the group. So we have a great session planned today with a great partner. The Q&A is open, so please feel free as we go along, ask those questions, go ahead and put them in the Q&A and we will answer them at the end. I want to send a warm welcome to our partners from Astrata. They were wonderful to join us to participate with our first webinar series, and we're going to have a great conversation. Couple quick housekeeping rules or a couple housekeeping facts. Slides and recording will be emailed to participants after today's session, so you will receive an email with both the link to the recording as well as the slides. If you want to submit questions during our webinar today, locate that Q&A icon at the bottom menu bar and then submit your questions and we will either answer them live or respond to them within the chat. So our speakers today, I'm going to host and kind of play moderator here, and we're going to talk with Dr. Rebecca Jacobson and Girish Chavan from Astrata. They are the co-founder and president and co-founder and chief technology officer. And so I will turn it over to Dr. Johnson.
Thanks so much, Allison. And first of all, I just want to thank you for inviting us to participate. It's very exciting to see this webinar, this new webinar, which is this expert series kicked off. And we're very excited to be up first at bat. So let me just start by saying that, Astrata is a company that helps health plans with the transition to digital quality. And specifically, we were really founded to create the technology to make that possible. And so one of the things that we really focus on when we're talking to our customers and clients is that the transformation to digital quality, this very important transformation, so important for value-based care, is really in many ways a set of transitions and transformations. And it's hard to keep all of the pieces together. So we kind of put together this slide to show you that what is going on really is a set of transitions. We are asking health plans to move from hybrid medical record review to prospective medical record review, from chart chasing to interoperability, from claims data to using clinical data with that claims data, from traditional measures to digital measures, and ultimately really to move from a more retrospective, reporting focused view of quality to one that is truly prospective and really focused on quality improvement. And so the key first message is it's really important to keep all of these elements part of the same transformation, because you really need all of them to be happening at the same time. Next slide. And one thing that perfect. So we're going to actually, let me just back up for a second and say we're focus on exclusively on this digital transformation. So we're going to kind of leave aside the prospective medical review, which is something that we work on a lot, and focus on sort of another very important part of this transition, which Astrata is very familiar with, and that is the move to digital quality measurement, digital execution of these measures. Next slide, please. Okay, and again, it's all part of one big transformation. So we've put together this light bulb slide to kind of give you the big pieces. Those are in those nice colored fonts there, as well as all of the component pieces of things that your quality team and associated teams should be attending to. So for instance, one of the most important things is developing your clinical data plan. You also want to be able to do moving to this prospective method for quality measurement, including moving your medical record review teams. On the right, you're going to see the things that are more focused on digital quality, such as being able to run digital quality measures and to transform your data into the formats that are needed to run those measures. And throughout this process, you need to think about how, again, do you focus on that intervention? Use that as your North Star. How do you move to a real measurement year? The entire measurement year, you are using accurate, up-to-date data to intervene in these populations and improve healthcare. And lastly, we always want to think about the workforce that is involved in this. Upskilling your workforce is also a component of this transformation. Next slide. So one question that we're often asked is, okay, tell me what the value is of this digital quality transformation. Once we move to digital qualities, what can we do now that we won't be able to do? And so we want to spend a little time unpacking that. And we'll go into a little bit more detail shortly. But I think the key things to remember, first of all, the digital transformation is going to allow you to use clinical data at scale in a way that you haven't been able to use it before. And right now, traditional HEDIS, especially as more and more clinical data is being used, is operationally much more difficult based on the technology, the HEDIS engines that exist right now. And that is going to change very dramatically with the new engines as they begin to be used. It will be operationally much easier to run HEDIS prospectively. And we'll see in a moment that the timeline will change from your vendors as well. In traditional HEDIS, you're often dealing with less complete rates. In digital HEDIS, we're going to see more complete rates. And that's been, I think, very nicely proven out through the ECDS transformation that's kind of preceded this digital transformation. Obviously, the use of clinical data, as we talked about, and I think one thing that's maybe a little underappreciated is that digital transformation, and this is always true, is associated with a lower cost of ownership. And we're pretty sure that that's going to happen here as well. So we want to create a much more efficient, more real-time approach to digital to quality measurement, and that will have a lower cost of ownership and less, manual operations that are often used in these operations. Next slide. So let's dig in now for a minute with what is the change, the timeline that we anticipate for our customers. Girish?
Right. So on the left, you can see the traditional HEDIS timeline. This is what's happening today. And on the right is the digital HEDIS timeline. And we can start with number one, when the NCQA is releasing their specifications. That, by the way, doesn't change in both of these scenarios, but there are some important differences that I'd highlight. So today, let's assume it's the measurement year 2025. So the initial specifications typically get released by the NCQA in August of the previous year. And the vendors are then coding today these traditional engines. They are proprietary engines to adapt to the new measures that are going to be released. They have time until July of the measurement year to certify these measures. That's when they certify them, and then they start rolling these out in the Q3 to Q1 of the reporting year. They are rolling out these measures to their customers. Now, what's different in digital HEDIS, and this is true because Astrata, for example, is a native digital engine, which means native engines can compute these measure packages as is. We do not have to recode our engine. We don't need to spend that time to adapt our engines to the new measure specs. So that really shortens the timeline. So now when we are looking at NCQA releasing the specs in August, we feel by October, we should be able to have our engine switched over to be able to compute these new measures. And as soon as beginning of Jan of the measurement year, we will be able to provide these measure packages to you as the customers to run during the measurement year. That's an important difference because now today what's happening is you're using the previous year specs, you're adjusting the dates to start to do prospective runs of your engine until your vendor is switching this over. Instead, with the digital engine, that's a native digital engine, that timeline is going to be shrink substantially. That means starting Jan 1st, you have the ability to run with that year's measure spec. Now, of course, the measures will get finalized, the spec will get finalized in March, but that should be a minimal impact on the actual measure rates.
Girish, can I ask a quick question there? It seems like this new architecture, the native FHIR CQL architecture, is much better suited to a ecosystem where measures are changing frequently, where there's more uncertainty, where you don't necessarily know that the measures are going to be exactly the same as they were the last year. Is that accurate?
That's true. I mean, I think the technology itself is suited, and that's why I think it's fast becoming a standard, and NCQA has picked this as a way to make these changes much more effectively, but also rooted in the standards and the FHIR implementation guide. So there's going to be a lot more precise documentation coming out as part of using these standards to release these measures. Okay. Next slide, please. Now, let's talk a little bit about how to get started in this journey. We've been working with our customers for a long time through this transition, and we realized there's a lot of confusion and uncertainty around how to approach this in a structured and efficient way. So we developed this phased implementation maturity model that helps you make steady, manageable progress towards a fully digital operation. So it all starts with phase one. Phase one is where you understand the data and the technical requirements for these new digital measures. These digital measures natively run on FHIR, and vendors will offer you different solutions. For example, Astrata offers you an option to ingest FHIR data or a flat file format. So that's the main step, though, there is to map your existing data not just the admin and existing supplemental, but even as you're bringing in new clinical data sources, to map that in a manner to meet the requirements for these digital measures. And what's important here is that it's not simply a mapping exercise done in isolation. You have to run these measures to see what the results are, compare the results, and then go back and adjust the mappings. So that's phase one, is where you are completing the mapping of your data, identifying any data gaps, issues that you may have to meet these digital measures. Phase two is the benchmarking phase, where you are gaining trust in the accuracy of the results. So you're running these across your lines of businesses, across all of the measures in a methodical manner, and using that process to identify any discrepancies that may be there. And there may be changes and differences from what the expected results might be, and that's okay. The goal here is to gain the trust and the accuracy to know why there is a specific discrepancy, that you can explain it. And at the end of phase two, you've gained enough trust in the accuracy that you can enter and parallel report, which is the NCQA's requirement to report your digital and traditional rates for a year together. So you are ready to report in phase three, and you are also ready to start to use these measures in production for quality improvement and other use cases, and leverage the benefits that Rebecca talked about before. And finally, phase four is when we are at the end, where you've transitioned to a fully digital HEDIS operation. You're using the digital engine for reporting, compliance, analytics, not just reporting. I'll say this slide, this materials, and a lot of other supporting materials is all publicly available on our Astrata website. So feel free to visit that and learn more on this topic. Okay, but before you get started on this plan, I think one of the key steps for us is for you to get buy-in from your executive leadership. So let's look into that next. Next slide, please.
So this is something that we are asked a lot about, and that is, how do I build a business case? How do I build an argument for this transformation? As a quality leader, you may know how important this is to you, but you have to explain this, obviously, and argue for the resources that are needed to make this transformation. And so I would say, we think about sort of 5 really critical things here. One is that any new technology, and something as new as this, you're often in the place of needing to explain the importance of it without maybe being able to give a, sort of spreadsheet level, one-to-one financial accounting of value. And that calls for a different set of, skills in how you're going to talk about this. And I think the best way to talk about it to a senior leadership team is really by starting with the opportunities and the risks. So tremendous risks, in my opinion, of being too late to this, because we know from numerous studies, many of which have been done by the NCQA, the critical role that clinical quality plays in getting to a complete rate, to having much more accurate information across these populations in terms of their true gaps. So it's very important that as this transformation unfolds, that you do not miss the opportunity that you have to improve the quality of healthcare and to reduce the potential liabilities, that's the risk parts of it, to reduce the potential liabilities that some of the other parts of this transformation will have. So for example, the elimination, the retirement of the hybrid methodology produces certain risks to programs like the STARS program, like Medicaid P4P programs, and digital quality is a way to address those risks. So I think the first thing is to focus on opportunities as well as risks, including the risks of non-action. Now, even though you may not be able to build out like a line-by-line sort of spreadsheet type analysis, I think it's absolutely possible to start testing these technologies, whether that's digital quality or, let's say, the use of natural language processing for your prospective review with unstructured documents, whatever the technology is that you're going to be using. Build those pilots, get the initial results, show that you can extrapolate, and do that in a way that you can start to build these financial ROI arguments. I think this is also very important. Third, I would say, or maybe fourth, I would say, as you saw from our first slide, this is actually a complex transformation that requires a lot of pieces and involves a lot of stakeholders. And number 1 and 2 on that list, in my opinion, is your CIO and your interoperability lead. So go make friends with those folks because they have a very important part. They really hold on to a very important part of this infrastructure. They're already working with FHIR. They are figuring out how to manage the interoperability rules and the same technologies that they are thinking about, the same processes of data mapping, et cetera, that they are working on, you're going to have to do too, maybe in a different way, in a different domain, but there are similarities and you can really work together to develop a plan that your senior leadership is going to understand and buy into. And then finally, kind of alluding to that, one of the things about any transformation, I think it's for sure true here, is that leaders need to learn to lead up, down, and sideways. Leading up, we've talked about how do you convince your senior leadership team. Sideways, that's going to find your CIO, your interoperability lead, maybe the head of risk adjustment, and other parts of your health plan that are also going to be using clinical data. And then also don't forget about your teams because they are going to experience this transformation and transition, and it can cause stress. So I would say focusing on upskilling, making sure to communicate what is going to happen, what is the timeline, how do we plan ahead, are all ways that you can get ahead of some of that stress. So Allison, I think I can turn it over to you now to walk us through some questions.
Yes, absolutely. Thank you so much. We do have some questions. I'm going to grab a couple from the chat or from the Q&A real quickly, and then we'll jump into some questions that we had planned to dive into today. So one of the questions that was in the chat that I thought was great was asking about how state measures can use the measures when they're changing on a frequent basis. And one of the components with digital quality is the measures are still changing on the same cycle. We're still following our same NCQA timeline, so they're not seeing anything different there. That biggest difference and that biggest value is the speed in which you're able to execute and use those measures. So instead of that month-long development process and execution, those digital measures are able to be capitalized on and used a lot earlier, but still not creating a lot of burden by having frequent changes that have to be maintained. And then a couple of these we're going to save until we get to the end. And then I also wanted to make, just kind of reiterate to what we heard is that there are another one of those values of our digital quality measures is that it is a standardized definition. So we take away that interpretation. We take away that human component of determining what the specs mean that are different from organization to organization. And it's going to be the same execution and the same implementation across the board. So we'll go ahead and jump into our first question. Kind of our first plan question is, what are the key steps that an organization should take to start building out their own FHIR data strategy?
Well, I'll start with this one. Let me start by saying, I think we could even maybe step back a few feet and say, what are the key steps an organization can take to build their own clinical data strategy? Because I don't necessarily think that you can, at the moment, focus entirely on a FHIR data strategy. I think there will come a time, and I think it's not that far away, when much of the data will be available in the FHIR standard, and we will make progress towards a much more interoperable ecosystem, but we're not yet there. And I think that health plans need to have a very broad definition of their clinical data strategy. It should not just be about FHIR. They need to recognize that all data has immense value. And even now, you may be focused on let's take what we've got and be able to use it, map it to FHIR and be able to use these technologies and then be all the more ready for a fire hose of FHIR data coming at us in the future. So I think firstly, it's being aware of what you have today and recognizing the value of it but not at the expense of what's coming tomorrow. I also really think that, sort of hearkening back to what I said a little bit, a little while ago, this is really where you need to be talking. I think as a quality leader, it's very important to be in frequent communication with the interoperability lead, who is likely under the CIO or in the IT department, who is already starting to think about how do you manage this type of data? How do you get this type of data as more becomes available, even from individual practices and individual EMRs, et cetera, electronic health records, et cetera. But I think you have to take a very holistic approach would be my recommendation.
Excellent, thank you. Move on to our next one. How should organizations think about running or executing their measures with this new transition?
I can take this one, Allison. So I think what's important is to not think of this as a very sequential process. As we've laid out in our phased implementation plan, when it comes to data mapping, that's the first step of getting these measures executed. Don't think of it as having this grand project to map your data over a long period of time and then starting to execute. Because the execution of the measures, even if it's on a small subset of your population, is going to help you discover and going to teach you a lot more about what these measures need and where your data mapping might have some issues. So I think that's one of the key things. Also, it's be prepared that this is an iterative process. You're going to map, then you're going to execute some of the measures. You're not going to boil the ocean and execute all of them in one shot, and have that as an iterative process as you slowly build things up. For example, when we work with our customers, we identify certain specific measures and certain FHIR resources that you focus on first, and do that in a staged manner. But it's iterative. Be prepared for that it's an iterative process, not a one-shot deal. And also recognize that these measures are different, and you will get different results. So it's important for you to build trust in the accuracy and go through that process of understanding why measure is calculated the way that it is. And then finally, beware of the scale problem. I don't leave testing this technology at scale until too late in the process. That's something that Astrata has been focused on right from the start, because we know how critical it is with new technology to feel comfortable in it running at scale. So that's something that you should test also pretty early on in your process.
Excellent, thank you. And I just wanted to add on and say that I love how you talked about it being an iterative process and starting slowly and kind of that building blocks approach. And as we created our phase documentation and our timelines to get us to that 2030 deadline, that's exactly what we were thinking, is slowly build those pieces in together, test one small piece, take on that next piece, and kind of continue to build and iterate. So I love that, we're able to expand that across the entire transition process. Okay, so next is, what are our common pitfalls that typically happen within that digital transition?
Well, I think you've heard some of them already, but let me kind of review and add to them. I think for us, often number one is not understanding the importance of a clinical data strategy, and really having sufficient buy-in, having it like at the top of the organization. It's not something that just, that quality can do on its own. So you really need to bring in those stakeholders and make that, really push for that. Most health plans understand how critical clinical data is to their future across many of their operations and functions. So this should not be a surprise to anyone. But getting to a real clinical data strategy is still very challenging for most health plans. And I think you really, to do that, not only do you need to link arms with all these other people that we've talked about, but you really have to think about it as a buffet, not as a main course. You are probably going to have to do a lot of different things in order to substantially increase your access to this data. And it won't just be one, it's not going to be solved with one process, one technology, one vendor, one HIE, et cetera. So that's number one. Number two, I would say I'll go back to what I said at the very beginning, which is this is a complex transformation and it requires a lot of pieces. Individual pieces have lots of steps, but there are a lot of pieces that may not immediately seem so critically intertwined, but truly they are critically intertwined. So if your CIO is off dealing with the interoperability rules and, maybe setting up a FHIR, environment, et cetera, well, that's very important for your digital quality transformation. And you need to know about that and be collaboratively designing, the architecture, the process that is going to support use cases that are going to be built on that ecosystem. Girish, I'm guessing you have a couple more.
Sure. Yeah. And I think you touched on to one thing to just reiterate. I think with FHIR, predominantly at health plans, the focus has been on meeting CMS interoperability efforts. I think one of the pitfalls will be if you do not sync those efforts with the data required for quality. It's built on the same standards, but the FHIR IG is slightly different. It's important for you to coordinate those efforts so that you're mapping your data once into FHIR and it meets all the use cases, not just quality, but other use cases that are also opened up by converting this data to FHIR. And I think I touched on these a bit prior. I think working on the scale issue early on is important to gain confidence. I think the other pitfall could be not sequencing these activities correctly to just reduce the churn. You may end up stopping and going back and forth if you don't sequence your activities in a way that lets you make steady progress. And this goes along with the point of it being an iterative process that you should plan for, not something where you can have a project that has a fixed timeline and it's one and done. I think that's one of the key challenges and different way of thinking about this project than other projects before. And then I think we've touched on this before, but one of the key things that you have to do is get that buy-in from the executive leadership. Know that this is a complex transition and transformation of how quality measurement and operations will operate. And I think having that buy-in and long-term commitment from your executive leadership is important.
Absolutely. And that's a great tie-in to our last question of our prepared questions is how do you build that business case to start demonstrating that value and gain that buy-in from your leadership?
Well, I touched on this, I think, in the last slide, but let me read a few things and maybe expand on a few things. Like I said, I think start with risks and opportunities. They need to understand both. And where you can use a ROI-driven analysis, do those small test cases, show what you think this is going to do in terms of the speed by which you're going to be able to have this data, the completeness of the data, the value of that to your organization. I think that the publications on ECDS and the impact of ECDS are an excellent starting point. And you can take that and say, now what if we could do this at scale? What if this was not a 6-month process to get this data through, but actually we could use this right at the beginning of the measure me, or for example. So building that more detailed business case is also very important. And that's going to happen stepwise. You won't be able to do that right out of the gate. You may be depending more on that risk and opportunity level analysis for your leadership, and then bringing in, an initial couple of ROI analyses. And then as you get better at this, I think you'll get more and more, because I think you'll see quickly once you start computing these measures, how much faster, easier, more complete, and more accurate it's going to be. I would say the other thing that I think I touched on before, which I think is really important, is you need to have a North Star for all of this. So when you're talking about it, you're telling a story that's based on that North Star. And to me, that North Star really is moving from a reporting-focused approach to quality measurement to an intervention-focused approach to quality measurement. And that has significant impacts on your organization, positive impacts on your organization, and very positive impacts on the members that you serve. And then finally, I would say this, like I said, is very much about linking arms with others, both internally and externally, choosing your partners internally and choosing your partners externally. You're going to need to rely on those folks and organizations to help you to get the data that you need to convince your senior leadership about the long-term value of this transformation.
Wonderful. So we're going to jump in, and we have quite a few great questions popping up in our Q&A. So go ahead and please keep submitting and entering those questions. I'm going to summarize a couple of them and bundle them, since many of them are on the same topics, which is always wonderful. But can we spend some time talking more about the differences between the results and the outcomes you're going to see between that original engine and that CQL engine? And what are some of those things that organizations should expect to see that are different as they go through that testing process?
Yeah, I'll try to answer that. I think right now at the stage where we are with our customers, we are getting very close agreements to what the traditional expectation would be for that member. I think the differences can be when you have certain codes, custom codes that you're using in your system that aren't part of the value set, and then that needs some additional mapping, etc. In terms of the measure logic itself, these measures, from as much as I understand, are equivalent to what the specifications are, but maybe someone at the NCQA wants to shed into if there's any expected differences that we should see.
Can I just add one more thing? And
Please.
you know, as you're going through this process, I mean, Girish is talking about kind of customers who are fairly far along. We've been through this whole iterative thing many, many times. When you're really just starting out, you're going to find data quality problems. You're going to find a lot of missing data. You're not going to understand, what is this actually, this resource? What am I supposed to map to it? So the initial rounds of this can be very disorienting and confusing, actually, I would say. And you may you might execute these measures and get a zero result the first time you do it. You might execute it and get a result that's like, this is way too low. This can't possibly be right. So just expect that and understand that, like, as you go through the process, your job is to figure out how to push those up to get them to where, Girish is describing. Is that fair, Girish?
That's a very good point, Rebecca. I think to give you an example, the zero result examples, initially when we ran a data set, it was 0 or like 2%. And then we realized it's a simple change in one of the resources that wasn't about the status or of the type of the resource, and suddenly it jumps up to 70 or 80%. So that's why sequencing these activities in the right order is important, because you don't want to spend a lot of time churning and generating the incorrect data. And that's what we focus on with our customers. But yes, the data quality issues that's why that's our first phase, because that's going to be where most of your discrepancies in the results are going to be.
Excellent. We do have a couple more pretty specific questions as they pertain to FHIR. One of them is around looking for some recommendations of how to dedupe the FHIR data, especially when data is coming in from providers that already may exist in the administrative data, and how do you ensure that you're not having those overcount scenarios?
Yeah, that's a great question. So the FHIR standard is built for keeping that data separate, but with the source information and provenance information. So in a way, I would say you shouldn't be too concerned about having what you would say duplicate data, because even the measures are designed in a way where they are going to pick the information that is available. It's not necessarily going to overcount because you had multiple pieces of information. The measure logic is going to take care of where it needs to deduplicate when it is counting those pieces of information. I think having the same information validated from multiple data sources has other benefits and advantages. You'll be able to use that in understanding how much confidence and evidence you have in other data sources that you're coming in. So it's not necessary, in my opinion, to focus too much on deduplication of the data. Now, data accuracy is a different story. If you're getting the same exact piece of information in FHIR as part of your FHIR ingestion mechanism, that can be eliminated, where you're actually updating the same data from the same source twice. That's definitely something that you should clean up and deduplicate.
Awesome, wonderful. And a couple other staying on the FHIR themes, and then we can move to some of the other themes around getting started. Are there different ways that organizations should get started, start addressing it, how to get that clinical data? Are there potential barriers and or costs that they should be aware of?
So I'll just start with the clinical data issue. I think you have to be prepared for costs here. I know that they're going to come down. They're already starting to come down, but you're going to incur costs to get this clinical data. And this is why it's so important to build this argument that's going to help you to unlock the resources that you're going to need from your senior leadership. I think you can think about this, as I said, as a buffet. If you think about your provider network and where you get data from, where you need to get data from, they're very heterogeneous. You've got some plans may have, depending on the type of plan you are, some plans may have a regional plan for example, may have a finite set of providers from whom, a significant part, 50% or so of their data comes from, and then a very long tail. So you're going to want to approach the big lump and the tail pretty differently in terms of how you're getting that data. And I think you should think about it as a buffet. You should be out there looking at all of the available possibilities, whether that is working with a cloud-based EHR, getting data from HIEs, getting data directly through aggregators, working with your providers at smaller places to come up with more ad hoc kind of ways to get at this data. But I think you really have to think through how not to try to kind of pigeonhole it or kind of fit it into just one way of doing things, because I do think it will take a number of different approaches to succeed. But absolutely.
And I'll just
Yeah, sorry, Girish.
And no, you're fine. Sorry. And I'll just add that again, don't think of this as sequential. As while you're working on your clinical data strategy, work with your existing data, because that's going to be always a step that you have to do, is to map your administrative and existing supplemental data feeds. Not all of these feeds are going to turn to FHIR on the same day. So you will have this, as this transition goes along, you'll still need to continue to ingest those traditional data sources until they switch to FHIR.
A really good point. Think about this more.
Yep.
Gradually, these things are going to start to converge more and more into standards-based data feeds. But that will not be true on day one. And so you have to really account for that in your plan.
Absolutely. Great advice. So staying within our FHIR theme, great questions. I love the questions coming in. So when we look at the FHIR and the size of the FHIR data that could potentially take longer times to process, how do you deal with that amount of additional space and processing time?
No, that exactly speaks to the point that I was trying to make with these new technologies, is you have to gain trust and ability to scale this. So it definitely is a challenge, though it is not necessarily something that's intractable. Astrata, for example, we've run this at scale with large amounts of data. It's just different engineering techniques that you have to use in terms of enabling this, using really techniques that have been widely used in other industries for processing large amounts of data can be applied here also. I think it all goes into the architecture design of your solution.
Yep. Wonderful. And so when we look at that clinical data, is there really a better way that organizations should plan on entering those clinical data elements or results, such as colonoscopies or pap smears or mammograms, at the point of care when those look back periods go back further, or there's some strategies around how to work with that data to make it the most useful?
This is, I think, one reason why, we didn't touch on this too much, but I think this is one reason why when we go into one of our customers, we're usually talking to them about two things. We are definitely talking about digital transformation, digital quality, how to run digital measures, but we're also talking to them about how to use their existing kind of medical record review to, get that working on steroids with natural language processing, because unfortunately, a lot of that data exists. Primarily, the longer the look back period, the more likely it is that that member has been at another health plan to receive that care. And you do not maybe have data that is necessarily in a structured, discrete format that you're going to be able to use. So again, it goes to the buffet idea. You really need to be approaching it in many different ways in order to get an outcome that is going to be satisfactory. And it's particularly true with these long look back periods.
Okay, wonderful. So we did have a question around the CQL engine itself that executes the measures. Currently, if organizations are purchasing digital content services through NCQA, that includes the CQL reference engine as well as the digital measures that execute within that engine. That is one opportunity. There are other options when organizations may already have their own CQL engine or engaging with different engines. That really is a business decision for that organization to think about what your long-term goals are. If organizations are looking to do more with those CQL engines than just the HEDIS measures, they need to kind of do that technical assessment and that processing assessment internally to determine what's the best fit for them. But please reach out to myself or any of us here at NCQA directly, and we can, have a further conversation about what some of your specific use cases are and how we could support that. Let's see, and then we had one more question around what digital only means, and how that actually executes. So what that digital only reference means is that the volume 2 measures, all of the ancillary services that go along with the HEDIS process are all done in that digital interoperable format. So we're not manually coding measures off of volume 2. We're not manually doing all of the steps that go into that HEDIS process from beginning to end, but we're utilizing the interoperability and the standardization to support the execution of the measures with the access to that clinical data. I'm not sure if you guys want to add anything else to that.
Nope.
Okay. We do have a question around reporting. At this point in time, reporting will stay the same as it is. The movement to digital quality measures is really changing how the measures are executed and accessing the clinical data upstream. That data will all still be pulled together, and measures and reporting will all stay the same as it has been today. And I think we will wrap up with our last questions around how organizations could potentially be running digital measures themselves, and what is that advice to health plans.
Okay, I think I'll take that one.
Mm-hmm.
So the question is, kind of most of what you're saying seems to apply to organizations running these digital measures themselves. What is your advice to health plans who are using a vendor to run their measures? And let me just say that, just like it is for today for HEDIS traditional measures, there are plans that have built their own HEDIS engines. There are those that on the other side of the spectrum are using a vendor, and actually the vendor is not only providing the technology, but it's actually running, all of the operations are outsourced to the vendor too. And there are those that are in the middle that might be licensing the technology and then doing the runs, et cetera, themselves. So those three buckets, the same thing applies for digital quality too. And I would say that right now, there are folks that are out there that are figuring out, how do I create what I need, do it yourself, build it yourself from existing engines, existing technology that is out there. That's not what we do at Astrata. We are a vendor. We provide the other two possibilities. So I would say everything that we've talked about here is equally applies to any of those three buckets. It's just the question of who is doing what. And, you know, if you're thinking, and for sure the clinical quality thing, that belongs to you regardless of which of these buckets you're talking about. But any of the topics that we talked about, including the issue of scale, is something that you're going to want to be dealing with, whether it's your IT shop, if you're a quality leader and your IT shop says, I can do this, you know, we should be the ones creating this engine. You want to be addressing these issues that we have brought up directly with them. Same thing with a vendor. You want to be addressing these questions to the vendor as well. You know, how do you scale? Show me some data on how you scale. How do you deal with state measures? You know, all of these kind of questions that have come up, I would say these are the very questions that you want to be asking either to your internal teams or to your external vendors.
So I will do a last call for our questions today, and during that time, we'll go ahead and wrap up. Thank you again, Astrata, for joining us and sharing your expertise and your experience of kind of being out in the wild and doing this in the real world. Thank you for joining our first series of our Digital Quality Expert webinar series. We have more planned. Our hope is to do these on a monthly basis, and we've got some great ones planned for June and July. So be sure to stay tuned to our mailing list for all of those updates. And as always, reach out to any of us at any time here at NCQA. We're always happy to talk digital and really offer any support or hear what your experiences are and, you know, what we can do to help and support through that transition. I'll hand it over to Astrata for any last comments.
No, thank you so much, Allison. Thank you to NCQA. It's been a pleasure. And I know this is going to be a great series. I can't wait to see the next one.
Yeah, wonderful. Thank you, everyone. Have a wonderful rest of your day.
Thank you.